Thank you for joining us at Retina Connect. This is our third episode. Today we will be addressing the topic of managing proliferated diabetic retinopathy. Retina Connect is a program of events dedicated to sharing and discussing practical surgical experience. I am Monica. I am from D.O.R.C. I would like to introduce our presenters this evening. We have Gaurav Shah from the Retina Institute, Mike Jumper from West Coast Retina, and Dean Eliott from Mass Eye and Ear. Thank you for taking the time to do this presentation for us this evening. And without further ado, I will pass this to our moderator this evening, Dean Eliott.
Well, thank you, Monica, and thanks to Dutch Ophthalmic. Really appreciate you sponsoring this meeting, which will be discussing surgical management of diabetic retinopathy. Monica, I sent you a text. If you don't mind, take a look at that. And we will get started. Thank you. So I have with me here today my esteemed colleagues, Mike Jumper from San Francisco, Gaurav Shah from St. Louis. And you know, it's been 50 years since Robert Mockemer introduced vitrectomy surgery. And what was amazing was the first case ever done was for diabetic vitreous hemorrhage. And this was the day of no ultrasound and no endolaser, yet the patient started with 200 vision and ended up 20/50. So Mike, what do you think happened there? How did he get so lucky?
Well, I think he got lucky. He may have had some knowledge that the guy had some vitreous separation, but I think it all had to do with the status of the vitreous. He was just fortunate that when he went in to remove the vitreous, there wasn't a big traction detachment. This was more just a bad ochre vitreous hemorrhage that had been there a long time and wasn't clearing.
So you're right, there was a total PVD. And, you know, he got very fortunate there because he had no way of assessing what was going on back there. And the total PVD we'll get back to later, because that's the best case scenario when you do these types of cases. It's real easy when there's a total PVD. All right, I'm trying to advance. Monica doesn't seem to be going forward. Okay, here we go. So, you know, Robert Mockemer and Tom Auberg published this seminal paper way back when, 1977, and the three indications for diabetic vitrectomy, you could see most of the cases were for vitreous hemorrhage, but there was also traction retinal detachment involving the fovea and combined traction rhegmatogenous detachment. And then they did another paper in '87, the same guys, and they expanded their indications. You can see severe fibrovascular proliferation, but that means severe fibrous proliferation and or severe vascular proliferation. And Mike, you have a case you're going to show us a little later of severe vascular proliferation. You can see a few other indications. And then today we have a whole bunch of things. We occasionally do it for diabetic macular edema, although not that common anymore, but Gaurav's going to touch on that later. And also traction retinal detachment threatening the fovea, which is interesting because we didn't do that way back in the day. So here's the most important slide. The goals of diabetic vitrectomy are to remove the anterior, posterior, as well as tangential traction, maintaining hemostasis and preventing postoperative complications. That sums it up. So we're going to talk about which patients are good surgical candidates with respect to duration of hemorrhage, duration of macula off detachment, which cases of mac on detachment do you operate on, the extent of ischemia, does that help you make a decision? So here we go. Mike, when do you operate on diabetic vitreous hemorrhage?
Yeah, you know, I mean, I think that the indications have sort of changed over time as the safety of vitrectomy has improved to some degree, and our availability of other treatments such as anti-VEGF injection therapy. But as a general rule, I think on the next slide I have, you know, what I discussed with the fellows and how this had kind of come about over time with the D.O.R.S study and the ETDRS study and the diabetic retinopathy vitrectomy studies that have been in place in the past. But bottom line is, I think of it as, you know, if somebody's type 1 and if they're untreated, those are the to me, the ones that are most urgent to get to the OR if they've got a dense vitreous hemorrhage. And I'll try to do them, kind of sign them up and do them as soon as I can. If it is somebody that has known PRP by, somebody that I've seen the PRP, I know they've got good PRP, and it's a type 2 patient, I'm willing to wait as long as they are if it seems to me that this is just a problem of new traction on old proliferations. Most of the time, somebody comes in and they say, I just had a new hemorrhage and I've had great diabetic control and I had laser 8 years ago. And why am I having this bleeding now? Well, it's because you're having a PVD. It's not because anything is changing, vascularly in your eye. It's just that you've got new traction on old proliferation. So I'm willing to wait on that patient, but that's kind of my general guidelines.
And Gaurav, how about you? You got a diabetic vitreous hemorrhage patient in your clinic. They have some PRP. You don't really know how great it is, but they have some in there because you can't see the rest of it. And you're going to operate right away. You're going to wait a month. You're going to wait 3 months. The diabetic retinopathy vitrectomy study, hard to believe, but they said early vitrectomy was in 6 months and deferred vitrectomy was in a year. We don't do that anymore. So Gaurav, when are you going to go in? When do you think?
I think a lot of that depends on what the patient wants and what their goals are. But I think that at this point, given new technology, small gauge vitrectomy, if they're having blood for, let's say, a couple of months and you're still unable to do treatment, you've tried anti-VEGF therapy, I think it's not unreasonable to do vitrectomy in those patients because it's a different vitrectomy that we did now versus 10 or 12, 15 years ago. So I think waiting certainly is an option if that's what the patient wants. But I do think in these cases, people are impatient. They want better outcomes. And this is what they, potentially is a quicker way for the rehab.
Yeah, I usually wait about a month. If it's improving in a month, I might wait longer. But if it doesn't show any sign of improvement in a month, I'm going to operate.
Yep.
All right, some of these slides seem to be advancing on their own. But anyway, we'll try to figure out that glitch. Here we go. So you have a TRD involving the fovea. My cutoff is pretty much if they lost vision within the last 6 months, I'm going to operate. But if they lost vision a year ago, I usually don't. Now, of course, the status of the fellow eye is important, and there are many other factors, but that's my general guideline. Here you can see a patient that I operated on. This was about a 6-month duration, fovea off. And remember, you can't always know for sure how long the fovea has been off, but I operated and it really didn't help the patient's vision. You could see some non-perfused vessels nasally and the disc is a little bit pale and the macula probably was off, I think 6 months, maybe longer. What do you guys think? When do you time these cases?
Well, Dean, I would argue for this particular case that you probably served the patient well by doing the case and keeping them count fingers as opposed to them going on to hand motion, light perception, no light perception with this pretty bad traction detachment, but you can't know that unless you don't operate. And so it's a very difficult question to answer. I think that my decision is not based as much on how long the macula has been detached, but more on where I think the vessels are perfused. The real disaster cases that I've had, I'll do this great delamination and then I'll kind of realize the only vessels that were giving them any perfusion in their eye were the neovascularization vessels that I just took out. And they end up having worse vision or no vision afterwards. So, it's hard to determine that. In this case, it looks to me like there's some perfused retinal vessels that you can see pre-op. And so it makes sense to me to try to fix an eye like that. But I don't have as much a date cutoff on how long the macula has been detached as I do, how things look and what their other eye is doing. For instance, if I've tried their other eye and their vision didn't get any better, and this has got the eye that looks like this pre-op eye, here is their better eye, I'm not going to operate.
Gaurav, you got a comment about it?
Yeah, I think similar to what Mike said. I'm not sure when my video's not playing, but I think the issue is that what happens in these patients, what's the limiting factor is really the perfusion, as Mike said. I'm always sort of leery when you go into a diabetic eye and the conj doesn't bleed. There's really the sclera is pristine white. I have to think something bad is happening in the eye. And I think that vascular disease post-vitrectomy is one of the big issues. But there are patients like this, Dean, who are count fingers that this becomes a better seeing eye. And I've had many patients where you think, oh, 3 200s, and then the other eye gets an artery occlusion. So, nothing is lost in a diabetic.
Yeah, very good point. So Gary Abrams taught me something interesting. If you look at the picture on the left, let's say the patient had good vision until 2 weeks ago and comes in with this picture. Those cases are usually chronic extrafoveal detachments where they get a break somewhere underneath those proliferations, and then the fovea pops off, which would be 2 weeks ago. And you can see those proliferations, were probably years ago because they've regressed and it's mostly fibrous and not really vascular. And those are the hardest cases of all because you've got chronic membranes that are tightly adherent, atrophic underlying retina, and the patient previously had good vision. You're forced to operate at that point because it's probably a combined traction regumatogenous detachment. But I think he's right. Those are some of the hardest cases. Would you guys agree?
Yeah,
I would agree. Go ahead, Gaurav.
100%. I think, Dean, you and I have talked, and Mike, we've talked before, is diabetics who have extrafoveal traction and they're 20/40, but you see progression, whatever you do, they're not going to be 20/40. Okay. There's a good chance they probably won't be 20/40. Now, they might be.
So that goes to this slide. When the TRD is not involving the fovea. Okay, continue. Yep.
Yep. So I think that it's hard to convince these patients they need surgery. And I think that's an issue.
Okay, Mike, what about not involving the fovea? I mean, do you wait to see signs of definite progression, or do you look and see that it's a relatively easy case and therefore you can fix it so you don't have what Gaurav said where they actually do get worse? I mean, what do you do when you're thinking about whether to operate on a patient that has a bad TRD, but it hasn't gotten the fovea, at least not yet?
Yeah, I mean, I think that this is a decision you have to kind of make with the patient. Again, a lot of times that you're talking about this could be their better seeing eye, and so I'm hesitant to want to do anything. But what I like to try to do is see, document progression that doesn't involve the fovea. So if I see, okay, if they're seeing the shadows getting closer and I'm seeing the detachments getting closer, yet the fovea is not involved, that's to me a great time because we're both engaged in understanding that, we got to go. But sometimes I have a patient that I saw just a couple of weeks ago who I've seen her for 15 years with the same traction that in her only eye and great vision. She's a nurse and she's doing just fine. And there was a time when I was kind of eager to do something about it, and I'm glad I didn't.
Yeah, Steve Charles had that classic paper many years ago, which showed a lot of these never do progress to involve the fovea. But if it's marching toward the fovea, it's time to do something.
And Dean, I think what's made it easier now to follow, as Mike said, is really the wide angle photography, right? We can follow these patients and then they can see for themselves that, hey, this is a problem.
Yep. How about this? Ischemia. Let's say this was a MAC-off detachment. You've seen this macula. I mean, you already touched on this before, but do you have any general guidelines about what to do when you see a massively ischemic one? You sort of already said that maybe you wouldn't operate on those cases.
Dean, I think that it all depends on what the other eyes, that these people still have some peripheral vision. So I do think that you need to be cognizant. I wouldn't say no for sure, but I think that it's important the expectations are in line to what their disease is.
Yeah, similar, I think, to what Mike said before, not only their peripheral vision, but you don't want them to continue to get worse, so you can stabilize them, and that might be a good thing. Okay, so Mike, this is your case. Why don't you tell us about this?
Yeah, this is a case that Bob Johnson, my partner, followed for many years, for a long time. And this is a patient that, kind of shows some of the applications of the D.O.R.C study. But this is a patient that's got really bad neovascularization of the disc. This is pre-anti-VEGF era. So, and if you look at the next slide, the patient gets PRP, and you can see 4 months later, this is pretty tight PRP, yet the neovascularization is clearly worse. And now even 6 months after PRP, the neovascularization is just going hog wild. And this is a situation where it looks to me like it's pretty flat in V. So this is not, some severe, tractional problem. But vitrectomy can be useful in cases like this, in which you just want to get rid of the neovascularization. And this patient did very well after vitrectomy and just delaminating all of that neovascularization that was emanating from the disc.
Yeah, those are great points. How about this case, Mike?
I think this is a case where it's important to point out that, this is somebody that 4 months later goes from, pretty, ischemic looking retina, some PDR, to just horrible crunch. This is not from Avastin. This is just, progressive PDR. But when I look and see somebody like this, and I see a bunch of cotton wool spots, I think that this has got to be more than just diabetes. I think that this is horrible hypertension, renal disease, severe anemia, or something to cause such a huge progression of proliferative changes in a fairly short period of time. And, these are cases that, you got to watch carefully when they look kind of as ischemic as this does. The wide angle angiography to me is very important in these cases and stabilizing them, even if that was severe NPDR in the first photo, but it was super ischemic. I would think about trying anti-VEGF injection therapy and maybe laser if it was an unreliable patient, to try to kind of stabilize that eye.
Yeah, that's amazing progression. Okay, so we've talked about which patients are good surgical candidates. Just in general, what type of anesthesia you use? You do locals, you do general? What do you guys use for most of these cases?
Dean, I typically, number one, diabetics are always not healthy to go to sleep. Anybody can go to sleep, they have to wake up, so that's an issue. I do think that I typically prefer just local MAC anesthesia in these patients.
Mike?
Yeah, I try to do local MAC in some of these cases, but I will tell you, my biggest concern and the biggest complications I've seen related to anesthesia have to do with young type 1 diabetic men in getting local MAC anesthesia for these cases. Sometimes these cases are an hour and a half, 2 hours long. A lot of times these patients are anxious and move around, but I've had one of the worst complications I ever had was just a patient jerking around and moving their eye really rapidly in their head, or their head really rapidly, even though it was taped down. And so I'm pretty quick to do these under general anesthesia if I think they're going to be over an hour and a half, and I'm suspicious that they're going to be somebody that's not going to tolerate it.
All right, how about pre-op bevacizumab? So do you guys do this before your vitrectomy?
Dean, I think we talked about this. I don't do it that often. As maybe if out of 100 vitrectomies, maybe one, just because patient compliance is an issue in these patients coming back for surgery. But I would say the ones I do it on are the ones who have high blood pressure and maybe other risk factors for bleeding, but not too much.
Mike?
I was sort of surprised in talking to you all. I don't use Avastin much. First of all, I mean, I feel like it could be helpful in some cases, yet a lot of the cases that I'm doing with bad traction detachment are not either healthy enough sometimes to be able to go to the OR when we want them to, or are reliable enough to come to the OR when we ask them to. And so, putting an injection in without getting them to the OR within a week makes me nervous. But I've heard lots of presentations by lots of different people, all of which have been very smart and well done studies, that it does seem like it's helpful in being able to remove proliferations, but I have not used it.
Yeah, I agree. I don't use it either. I agree with all those points. Okay, so we said the goals here were removing the traction, maintaining hemostasis, and preventing the complications. So now we're going to talk about removing the traction. So you have to elevate and excise the posterior hyaloid, but in order to do that, you need to know where the hyaloid is attached to the retina and where it is detached. So for example, here's just a focal adhesion. And here you have a point attachment, probably one little neovascular frond, the vitreous contracted, and you got a flap tear. Those are, of course, the easiest cases because all you got to do is cut that one vitreoretinal adhesion and you're pretty much home free. This gets a little more complicated when you have a broad adhesion, several disc diameters in size. You can see the surrounding blood is in the subhyaloid space, and the further surrounding vitreous hemorrhage, more subhyaloid hemorrhage. That's harder than just a focal adhesion, but still, you only have this one broad adhesion to dissect. Moving up the ladder with more complicated cases is where you have the vitreous attached everywhere, except the macula. There's a little bit of a vitreofoveal separation. And those cases are the ones that can sometimes give you the subhyaloid premacular hemorrhages. It's obvious that the vitreous is separated from the macula, but it is attached at the disc, along the arcades, and all the way out to the periphery. So, Mike, here's your case. How do you do these cases?
Well, basically, it really depends as I go into the eye, figuring out where the hyaloid is attached and detached. Sometimes the blood helps you, so you can find, some potential spaces and get into that. I like to try to make a small incision into the hyaloid if there's a lot of blood, so that I don't have, 5 minutes of a basically snowed in, can't see anything because there's blood floating around everywhere. I try to suck that blood out through the smaller hyaloid opening so that I can kind of maintain a view. I try to, if I can get the peripheral vitreous removed to the level of where the proliferations are, I try to go all the way around and do that. And I think a video that I have will show that. And then I try to work from either the nerve out or some opportune spot where I can find a way to get kind of under those proliferations and delaminate them over the posterior pole.
And Gaurav, when do you operate on these? I operate on these pretty quickly. I see this. If the blood is layered and it's a boat-shaped hemorrhage, I don't worry too much because that means there's some space under there and the proliferations aren't that bad. But if I see this where it's not really boat-shaped, it's mostly just a round or oval hemorrhage or multiple little round or oval areas, that kind of means to me the vitreous is held fairly tightly close to the retina, and there could be a lot of proliferations under there. So I rather operate on these sooner. How about you, Gaurav?
Yep, same. I think when there's a lot of blood like this, you have no idea what's going on underneath. And I think going back to Mike's point, we see these wonderful diagrams in books about, where to start, and you start here and start there. But really, every case is different, and you have to find that opening and let that dictate where you're going to do it. It doesn't look anything like the schematics that we see, quite honestly.
Very good point. All right, so once again, knowing where the hyaloid is attached and detached, this is the worst case scenario where the hyaloid is attached everywhere. These are very, very difficult cases. They're often ischemic. The membranes are hard to remove.
Dean, in that case right there, if you look along the infratemporal arcade, it's sometimes hard to know which are the neovascular vessels and which are the native retinal vessels. And so, this is the kind of case where you do a great delamination, you realize, man, there wasn't much normal vessels there to begin with.
And Dean, you'll do cases. I was just going to mention chandeliers. This is a good cue. So I'm not a big fan of chandeliers, but here's a case where I think it is useful. This is showing the twin lead chandeliers and having depressed. This is 27 gauge. Now we can sort of use bimanual technique, remove the blood. You can shave down, do laser. But I kind of like sometimes doing this. This is a nice little approach. It's an older video, so maybe, I don't know how it's not as clear as we'd want it to be, but it allows you not to use scissors. And I haven't used scissors for a long time, but these small gauge cutters makes it quite, easier and safer to delaminate some of these membranes. And, certainly I think that scissors are great and people use them, but I have been relying less and less, but just using the cutter. And here's forceps that, you can use with it. So it's kind of a nice technique to sort of get in between these valleys. Got to be careful. And I typically do these on flow mode rather than vacuum mode. So you can see and then hemostasis, and then I think this just kind of shows the eyelid peeling afterwards. So I do think chandeliers in some of these patients are useful. Again, we don't want to spend too much money on these things, but I do think in some cases it's nice to do bimanual technique.
So that was really nice because you use the cutter for everything, and we'll talk more about that later. But you were able to do that by also using the chandelier and putting forceps in the other hand. So that was pretty slick. But I am going to show a video of one of your cases where you actually did use the scissor.
Yes, yes. So this is actually, I didn't have any, so I asked Kevin, he likes using scissors because, as I say, he's old. So you know, he was kind enough to send me this, but no, I think scissors are good. You can certainly use it for any different occasion, but this is a nice video of us showing the 23 gauge, you know, there's both vertical and horizontal scissors. And I'm sure Mike and Dean remember, we used to use the MPC scissors that were controlled. A lot of the fellows have not even seen the machine control scissors. But this is a nice example. You know, there's many different techniques. I think you just have to be cognizant what works out best for you. But I do think 25 and 27 have made it a little bit easier. That was a 23 gauge case.
So that's Kevin Blinder's case, right?
Yes. Yep.
Yeah, that was nice. All right. All right, Mike, why don't you take us through this case? This is yours.
All right. Well, this is just a horrible type 1 diabetic case. This is a woman who is as sick as can be with coronary disease, hypertension. She's had an MI, she's had a stroke, she's on dialysis, and she's 31. And that's just so sad. She had no prior eye care, and she came in 4 200s in the right eye and hand motion in the left. You can see these pictures here. So this is her better seeing eye, and she had that situation that Dean's talking about with you know, you've got these big fibrovascular proliferations over the nerve and along the arcades. And sometimes, you know, you may not even be able to really tell in the clinic, even with ultrasound, you know, what the status of the fovea is. But, you know, it's possible that she could have, you know, because she has subhyaloid blood in her macula, that she may have, you know, an attached hyaloid there. I mean, an attached fovea there. And you can also see here in this picture, one of the things that I think is an opportune place is there that more clear area temporal to in the temporal macula, where a lot of times that's a potential space where you can kind of start separating these proliferations from top to bottom. And so anyway, so I ended up taking this patient to the OR in that right eye. But here's a picture of her left eye, and this is at the first time of presentation, and she's got hand motion vision. This is her left eye, and so she's got bad traction detachment. She ends up getting a vitrectomy with membrane peeling, endolaser, and fluid air exchange in her right eye with very spotty follow-up. But about 6 months later, this is a pre-op, she's looking great. She's got 20/80 vision. She's able to see her phone. She's like very happy. And had a great outcome, despite, you know, the macula not looking great, but you know, quite a good outcome. So then she comes back now. She's 18 months after, I think, initial presentation. Comes back and she wants me to do her left eye. And so this brings up that question. You know, this has been a very long-standing kind of big-time detachment in a patient who's got hand motion vision, but given the other eye had done so well, I think, you know, we did this eye, and so that's what I have a video of. So this, I'm making a small break in the hyaloid. The hyaloid is way up out in the periphery, and I've made a small hole. Now I go over that hole in vacuum mode, and you can start seeing the retina as I'm pulling out blood from underneath the hyaloid. So this subhyaloid space I'm clearing out. Now this is something I kind of work on the fellows with, is this sort of maneuver in which you get, after you've cleared the blood out, you get underneath that hyaloid, that taut hyaloid, because it's so much easier to cut this way. And you go out kind of as far as you can, and you pull back after putting it under some traction, and you cut and pull back. And I think that that's a good way of separating the anterior vitreous from the proliferations that are more posterior. So I try to go all the way around and kind of create this separation. There's so many times where we've done this I'm not sure that I've gotten all the way around, but if I do it this way, I'm usually pretty certain that I've gotten the hyaloid separated. So you can see here, put it under traction and cut.
Yeah, so Mike, so what you did, what we were talking about earlier, you assessed where the vitreous was attached, which is over that entire fibrovascular proliferation, yet the vitreous was detached between those proliferations and the periphery. And your first step was to circumscribe the posterior pole and separate the
That's right.
posterior proliferations from the periphery.
So that's me going now the other direction. I'm underneath the very last 3 or 4 clock hours here, and I'm just making sure that everything's, now I've gone down, trimmed that vitreous, and now I'm using bimanual technique with the chandelier and the cutter, and I'm kind of just taking away these proliferations along the arcade. Sometimes I cut, more shallow. That's what I want to be, is more shallow initially. So I end up delaminating a little extra so that I'm not going too deep. That's the worst thing. So here I am delaminating these with the cutter. And in some cases, the cutter's just not enough. And so I'll go with scissors. And I think we show some scissors. Now, I use the chandelier light a lot and for these kinds of cases, because I'm doing a lot of it by manual, mostly with the cutter, but sometimes here with the scissors. Now you can see here, I'm kind of cutting it. I think that I'm shallow here. I'm probably going to have to delaminate another layer, but to me, I'd rather do that than go too deep. And so I start getting a feel. Once I get to a place where I know that I'm on just the surface of the retina, then I can go back to this area and kind of delaminate again. But now I think I'm right on top of the retina when I'm delaminating. So just using scissors and a pair of forceps, I'm able to put a lot of traction. Now I'm basically depressing and trying to take this peripheral traction off, which just making sure that the vitreous is off. It's pretty tight there, but I don't think that there's a break. Now the other issue is there's a lot of subretinal fluid, and I'm not sure if I'm going to be able to get enough laser in with the subretinal fluid that's there. And so I ended up making a break by doing a very controlled drainage in a place where I felt like it'd be good to get to put laser around. So you can see here, I'm taking out some pretty thick subretinal fluid, which has been there for years. And I'm going to laser around that and laser everywhere else, and then hope for the best. And
so I think, Mike, it's really nice what you showed. And I think a lot of times the fellows get, all of us have made breaks and detachments, right? I mean, it's part of the issue that these sometimes it's hard to avoid. But I do think if you get a break, to use that to your advantage and then drain the fluid, use it towards that issue, because a lot of times there is so much fluid you can't get laser in.
right.
And I think it's always an issue. Should we make a break in an area with severe tractional detachment? And sometimes a case like this, I think that was probably the best thing for the patient.
So this is the best part. Go ahead, Dean.
Yeah, that was beautiful. When I start a case, usually about a minute or two into a diabetic vitrectomy, I ask the fellow, what's the status of the vitreous? Where is the vitreous attached and detached? And invariably, they say, oh, the retina is detached in the macula. I said, no, I'm not talking about the retina. I'm talking about the vitreous. Because as Makamer used to say, we are vitreous surgeons. And I really like that you assessed where the vitreous was detached and you approached it based on where the vitreous was detached. You circumscribed the posterior pole. That was your first step. And you really showed a nice technique there because you figured out right at the beginning what was going to be the easiest approach, and that was to get under that detached hyaloid from the arcades all the way to the periphery. That was nice. So then you can continue here. You saw her a year later.
She didn't show up. She didn't show up for the post-op day 1 visit, the post-op day 7 visit, the post-op month 1 visit. She just didn't show up.
Shocking.
I didn't see her for a year later. We put her on the schedule every month. I had her on the schedule. We'd send her notes. One day she shows up a year later. Somebody, they called me from the front desk. She's here. And I knew exactly who it was. So anyway, she shows up. She's got pretty good vision in this right eye that I'd done the first surgery on. And then look at her left eye. This is the right eye macula. Her left eye is 2100. And so you can see the area of the drainage retinotomy. You can see that, despite having, lasering more posterior than I could have, the laser doesn't go all the way back to the arcades. And there's some subretinal proliferations. There's probably epiretinal proliferations, but this is pretty good outcome for what I thought was going to be a hand motion or worse, even post-op outcome. So
That's outstanding.
And Mike, God forbid nothing happens to the other eye, but this eye might end up to be her better seeing eye 20 years from now.
I won't know because she doesn't come back.
Yeah.
Yeah, quite amazing. Okay, so Gaurav, this is yours?
Yep. This is an old case, but kind of just showing, assessing where the opening was and sort of using the cutter and the light pipe with this hyaloid kind of lifting slowly. This is using the cutter and sort of going up in a 360-degree fashion. But Dean, this is kind of what you talked about, the nightmare in terms for patients who have an attached hyaloid, right? And fibrous proliferation. And this guy's vision was, despite all of this, was like 20/50. So, the lighting is not the best, but this just kind of gives it a general idea of following the plane, using the, I didn't use chandeliers here, but showing the ability for the vitrector to delaminate some of these areas. And it does take a little bit of time. Hemostasis becomes an issue, but finally you go through these little islands and you work one area, you go to the next area, you try to be patient with it. But I certainly think a case like this probably would have been easier now with 25 and 27, but this just sort of shows you now we can easily lift the areas. And again, the thing that's the saving grace here is this patient had pretty good PRP that we had done beforehand. So I think the PRP kind of helps you. And then once we kind of find that plane that Mike found in his case, then you just kind of go around, control the bleeding, and delaminate all of these areas. So it does take some time, but the video is kind of grainy, which kind of shows what Mike had talked about. And, this guy actually had a pretty good outcome. So again, I think sometimes the fellows get hung up. If one part's not working, go to the next part and keep working.
I like how you dissected posteriorly and then lifted when you thought it was safe to lift.
Exactly.
Most of the disease is posterior, right? Unlike a sickle cell where most of the proliferations are peripheral. So you
exactly
dissected around the nerve and then you lifted when it was safe. That was good.
That's right. That's right. Exactly. And that's kind of but that's what I'm saying, Dean. It never ends up like the schematics we see, right?
Yeah, but that was beautiful.
I have a comment. I think that it's very important to point out that there were parts of that hyaloid when you saw it in which are white and obviously vascular. And there are parts of that hyaloid which are more clear where you can see the retina underneath.
Yeah.
And I talked to the fellows about using basically kind of a plow technique in which you've got the cutter port into the part of that hyaloid that's more clear, and you plow along. You get kind of undermine it. You had enough space where you could kind of undermine and get the cutter port into the hyaloid, and you take it out in a ribbon-like fashion. And what you're doing is you're creating angles and spaces around those more vascular areas so that you can segment and delaminate those just with the cutter.
Exactly.
And really there's what you did looked, pretty easy and just 20 minutes of work, but, making sure that you're not pulling too much when you initially engage and pull off around the nerve, because there was attached vessels and there was proliferations that you were tugging on, not too much, but you tug anymore and you've got a nightmare going on.
Yeah, I think that's the point of no return, Mike.
Yeah. So this is the technique I like to use when the hyaloid is attached. Here we have segmentation. So I cut around the disc first, and you can see how the tissue spreads due to the tangential traction. And then I make radial cuts pretty much between the proliferations. And you could use the vertical scissors, which I have shown here, but some people use the horizontal scissors, or you saw Gaurav doing it with the vitrector. And you can do a lot of these with the vitrector these days because the port is so close to the tip, which we'll talk about a little bit later. But this is my general technique. And then you delaminate by slicing these proliferations off the retinal surface. And some people like to use a illuminated membrane pick instead of the instruments I just showed. and that's fine, whatever you like. So here's the case. I'm going to show you the video, but it's hard to actually understand what's going on in the video because there's a little bit of circulating blood and it's kind of a mess back there. But if I show you ahead of time what I'm going to do, it makes the video a little easier to see. So I'm cutting around the nerve in this case, and you can see I've outlined the little slit that I've made. It's a little arc as I'm going in the circle, and you can see again how the tissue separates due to the tangential traction. And then I've gone completely around the nerve here, and you can see the circle, which is actually pretty big because once again, it's stretched. And then I make some radial cuts, and you can see all I did was 4 radial cuts. Now I just cut in a line. I didn't cut in a V, but the spreading took place naturally due to the tangential traction, and these lines became V's. And I have 4 V's surrounding the disc. And then I did exactly what Gaurav did. And then I lifted, because then I figured there weren't too many proliferations in the mid-periphery, and it was safer at that point to lift up the posterior hyaloid rather than just grab the whole thing at the beginning and lift. Because of the tight adhesions posteriorly, I would have ruptured a vessel. So here's the video, but you'll see what I'm showing here, although the view's a little cloudy. And thanks to Dan Gong for editing with this. So you can see there's a premacular subhyaloid hemorrhage. I make my arc, I cut the circle. Now I finish the circle. Now I'm making the radial cuts using the vitrector. I didn't need to use the scissor. I made another radial cut. Here you see my 4 radial cuts like I just showed. And then I lift up each of these, exactly what Gaurav did. And here you see a pretty much clean retinal surface and looks pretty nice. This is
Dean, it's funny, it's almost exactly the same thing, but just different instrumentation, but the same principle.
Right, the same principle is not pulling too early, it's pulling after you've done your dissection. But I always love to go around the disc first. That's my favorite way of doing it. But like you said, it's not like a textbook. Every case is a little different. So Mike, what do you think? This is a different case. Mike, what do you think's happening here?
Well, I mean, I think that something that is underappreciated is the tractional changes that can lead to a macular hole. And so you can see this one pre-op, but a stretch hole that's there in the macula. And sometimes you don't know it's a macular hole because the retina is stretched so much. But, you know, Dean wrote a paper and discussed this many years ago. And I always remember that the percentage of cases with bad traction detachments that actually have a macular hole as well is pretty high. And so you've got to be mindful of that. And I think that's a really good indication for peeling ILM in these cases and using long-acting gas or oil to try to make sure that that macular hole, do as best you can close. These are tough cases. And, you know, not only do they get, can you get macular holes, you know, intra-op, or you find them intra-op, but you can also have them develop post-op, which is another important thing to recognize and be aware of.
So what's interesting about this case, you see the retina pulled nasally. So part of the macula is actually overlying the disc. And we had to not only cut all the proliferations, but try to get the retina to go back where it came from. And you can see in the post-op that you can actually see the disc. Once again, some non-perfused vessels, the retina is flat. There's a little circular thing. The macular hole was actually closed, but that's like pigment change in the middle.
You know, Dean, I think it's important in these cases where there's traction to at least stain the macula. You'll be amazed at what you'll find after you stain. And I think there should be very low threshold for peeling tissue on the foveal surface. If there is an issue of proliferation that you can't see without staining. So I would at least have people try to stain and see what's there.
Yeah, good point. So Gaurav, this is your nice video of we're going to switch topics and talk about visualization, but we'll start with posterior capsular blood that's obscuring your view. So why don't you tell us about this case? Yeah,
so this is a patient who had a vitrectomy a few months earlier, I believe, and then rebled, and he's phakic. So this is a problem. When the fellows want to clean the cornea and scrape the cornea, which I hate in any case. So first thing you want to do is make sure that get the blood off the anterior surface of the lens. But the second thing is always hard to get it behind the lens. So there's a ligament, there's a sort of a space behind the lens, Weigert's ligament. And what you do is as you hydrate, you make this blood, instead of sticking to the lens, it becomes more vertical. It then allows you to, I don't know what happened there, but,
Slides somehow have a mind of their own.
oh, okay. Well, what happens is that, so go to midway. What happens is as you hydrate, it's easier with your cutter to get this blood off. So we haven't caused a cataract. It's a little bit hard to see in 2D, but it always drives people nuts when we see this behind a phakic patient who's rebled the anterior vitreous. You know, you try to remove as much anterior vitreous, but this is really a nice technique we wrote up a few years ago. Dr. Chen was one of our fellows, but it makes removal of this blood very easy. Is if you hydrate that space, the blood becomes vertically oriented rather than horizontally oriented. And it works really well. And I use this all the time in patients who have rebled in phakic eyes. So it's a problem that all of us face. As you can see, you can beautifully clear it. And you see that little rim of blood? That is on the anterior surface of the lens that you want to get out. So you have a crystal clear view in.
Yeah, that's a nice pearl. Pretty cool little technique there.
You know, Mockemer taught me that, and I'm sure he taught you this, Dean, that, you know, what he liked to do for these blood on the posterior capsule of the lens would be go behind the lens with the vitreous cutter on aspiration only, slowly go right in the middle of the lens, slowly go up until you kind of capture that blood and then cut. So you're not touching the lens, you're kind of away from the lens. By aspirating, you're sucking the blood down to the cutter port and then you cut. And I've used that, but I like that technique. I'm going to try that.
And you know, Mike, I've tried that. I've done air fluid exchange. I've done all of these things, and I'll tell you, it's very frustrating in somebody who's rebled and who's phakic, and it's just your view is totally. And we found out the source of this guy's bleeding, but it just drives me crazy when you can't see details.
Yeah, so it's good when you go behind the lens and you aspirate. It's also good to raise the infusion pressure, because whatever you you don't want the eye getting a little soft and that lens moving a little posteriorly, because you'll hit it. So if you keep the infusion pressure pretty high and turn the aspiration up pretty high, you can inch your way close to the back of the lens, as you just heard Mike say. So this is great. Okay, so we're still on the topic of visualization. And, you know, a lot of us use triamcinolone. So, you know, Gaurav and I and a few other people used to give a course at the academy. And it was interesting how the St. Louis guys used to use a lot of triamcinolone. At the time, you know, nobody was really using it. And I was intrigued by it. So I started trying it, and I really love it. And we use it on almost every case now. We use it to stain the vitreous, but we also use it to see if there's a posterior hyaloid remnant. I actually think this is your slide, Gaurav, and Ischemia. So tell us about that, because you guys really opened my eyes to this. And I think you were the first guys that really did it commonly.
Yeah, I think that the credit really should go to our Japanese colleagues who sort of showed us this, that a lot of times, you know, initially, Dean, when we were doing this, we thought it was the ILM. And Brett Rosenblatt was one of our fellows, and we sent all these samples to Mort Smith in pathology. And then we figured out, well, it's not the ILM, but it's this cortical vitreous. So it really allows us to get all the surface proliferation off. Because even stains will not allow you to see the cortical vitreous, because triamcinolone is not a stain. It's just really an adjunct compound that sits on this. But I think removing this has increased our outcomes with less proliferation in the posterior pole and the periphery. So I really think, again, there are many people who do nice work without Kenalog, but I find it very useful for the hyaloid and the cortical vitreous.
Yeah, so we end up now many times staining twice, right? We put some vitreous in, put some triamcinolone in to see where the vitreous is, and we think, you know, we have a PVD and everything's gone, and then we put it in again, and exactly this, we find some remnants of the posterior hyaloid or vitreoschisis, which is common in diabetics. So I thank you for.
And one thing, Dina, I want to add for the fellows. Let's say you're doing a vitrectomy and you're trying to puff blood away, and it's not happening. You know for sure that patient has cortical vitreous. Put in Kenalog in. As you lift in that, you'll see an entire sheet of vitreous coming off with it, and then the blood will come very easily. But that's a really good clue.
All right, so Mike, do we have any questions from the audience that you want to address now? Or
Nothing's come in yet, but I just want to kind of make sure everybody knows that if you have any questions, type them in, and I'll be looking for them.
Okay, thanks. All right, so, visualization again is critical, for diabetic cases especially. So here we use wide angle. We use the Recite. What do you guys use?
I use a
Uh,
Recite.
Yeah, we have both the biome and the recite.
Okay. And then high magnification viewing, I think this is critical because when you use a scissor or even when you use the cutter, sometimes you have to put on a high mag lens. I mean, most of the time you can do it under wide angle viewing, but if you have good magnification, you're less likely to cut a blood vessel and do something bad. So I like this HTC lens. I think this thing is nice and stable and you get a really good view. What do you guys prefer for high mag viewing?
I think, Dean, something similar. I think whatever lens that comes with their pack, but I like a macular lens. I think that gives you the best stereopsis for me personally.
I tell the fellows that it's important to, once you get the kind of peripheral stuff sort of trimmed away, like I showed, I think that going to the high mag lens early will help protect you from creating damage, like Dean said. I like this same lens. I think that the foamy kind of rim does help to kind of keep the lens centered.
Another way to visualize that is you can actually use the biome with this lens as well. It'll kind of give you kind of a mid-periphery view with the contact lens.
Oh, nice. I didn't know that. Are you guys using intraop OCT?
We don't have it, Dean.
I
We
have it
haven't.
in one. Yeah, I have it in one OR, and I do try to use it in cases like patients who have bad vitreomacular traction, sometimes in diabetics, in which I'm a little worried that when I peel, I might create a macular hole. And so I like to look and see and be for sure, but I don't use it that often.
Yeah, I don't love it. The resolution's not that great, and there are often technical issues. Maybe it's operator error, but whatever. Doesn't always seem to give me the answer. Sometimes it's useful, but I'm not loving it at this point. So, we did talk about the evolution of small gauge, which has enabled us to remove all these proliferations and release the traction with the small gauge cutters. And each vendor has its own machine. Gaurav showed some nice pictures before of cutting basically everything just using the vitrector. That was not the way it was years ago. Also, the cutters now are high speed. I mean, we got some really pretty cool instruments these days, which has made this so much easier. And I think if you're older, like the three of us are, we have some perspective about how difficult this stuff used to be. And for you young folks out there, I assume almost all of you out there are young, it's really nice to just think how the field has evolved and use that as a way to think about how we can continue evolving, because we're relying on you to come up with the new inventions to take the field further. But they've done a great job, these companies, at producing really good equipment that enable us to do what we do. Now we have these cutters that are up to 20,000 cuts per minute. The port is open most of the time, so the flow is good. They're efficient cutters. There's less turbulence. That's critical, especially with the valved cannulas. I mean, so many things have just made operating so much more pleasant and better for us and our patients. We've got the ports closer to the tip. I mean, all these things have just been great breakthroughs. So we'll switch topics from visualization and machinery to relieving all the traction, like we talked about before. But sometimes you cut all the membranes. You've used your great visualization. You've used your great vitrectors and forceps and picks, and you just can't relieve the traction. And you just either have to do a retinectomy or put on a buckle or both. And in diabetics, there are two types of retinectomies. I like a lot of, I do a lot of these focal posterior retinectomies where, as you can see in the illustration, you've got a fibrovascular plaque that contracts, and either there's a pre-existing break or you make a break while you're dissecting. And in that case, you can just excise the whole plaque and drain the fluid and laser around it. And you can see this patient, did pretty nicely. So we do these in diabetics, the focal posterior retinectomy. You could do more than one if you need to. We try not to do too many in the same patient, but if you have to do it, you do it. And the other type is the large peripheral retinectomy that we're all pretty familiar with when we do typical PVR surgery. Or here you see a patient where I had to do a massively large retinectomy, but the patient remained attached, had poor vision due to ischemia, but still not terrible ischemia. The vessels were still perfused. The retina remained attached years later. I left the oil in, and I plan on leaving it in forever. You can still see the oil, but this is nice. And I had to do the retinectomy because of contraction. So you guys have any comments about the types of retinectomy or when you do them?
Go ahead, Mike, first.
Yeah, I really think that the focal retinectomies are extremely necessary in some of these diabetic cases. I mean, you've got this area where, essentially the retina has already been either severely damaged and does not have any kind of vision function. And you can either try to get that proliferation off, and I give it my best shot most of the time. Sometimes it works out that I can get that off, but if I can't, you're better off removing all of it and having a big retinectomy than you are to leave that proliferation and a break. So if you're certain that you don't have a break and you don't have a big area of proliferation, maybe you can leave it and just laser around it. But most of the time, I'd prefer leaving a retinectomy than a big fibrovascular proliferation, just because you can't be sure there's a break there. As far as the peripheral retinectomies, like a PVR type case, those to me are quite rare to have to do. And when you have to do those, you're kind of, this is like the eye is already gone and you're doing CPR on it. And I do think that, sometimes you can have a great outcome like this, but man, that's tough stuff, especially, bad ischemia, and keeping those from reproliferating is not easy. And so, I have not done that many of those kinds of peripheral retinectomies in diabetics, but that's the kind of case where I'd be thinking about putting a buckle on at the beginning of the case and going kind of full stop, just like Dean did with the oil.
Yeah, Dean, I think the only thing to add to Mike is that the picture you showed, if you do have an area of traction, then I do think that, and if you think you're gonna need to take it out, you can be pretty aggressive trying to get it out. Because if you know you're gonna do a retinectomy, then certainly if you make a hole, cut that whole part out. So sometimes I see fellows spending a lot of time trying to be careful, and it's important. But if you kind of know going in that, hey, you know what, most likely we're gonna have to remove this, you can be pretty aggressive.
All right. What about a buckle? You guys think it's useful to do a buckle these days in these diabetics? We used to do it a fair amount, but not too much these days. What do you think?
Dean, I think if you can save the lens by doing a buckle, probably worth it, especially for the really peripheral anterior traction. And sometimes you see these in diabetic patients who have bad hypertensive disease. They've got these peripheral fronds. They almost look like sickle cell disease eyes, but they don't have sickle cell. So I wouldn't abandon buckles in these patients, but wide angle viewing has helped with that. We used to do this more when we didn't have wide angle viewing. But I think that there are patients where rarely I would consider it, but I think sometimes people don't even consider that now.
Mike, what do you think about buckles?
I don't do many, but I definitely, in the pre-op assessment, especially if I can see that there's bad peripheral neovascularization in a young person with a clear lens, that I think that I can keep that lens from having to remove it, then don't hesitate to put on a buckle in those cases. And I think that there are certainly times when putting on a buckle is the right thing to do. And it's rare that I'm kicking myself for having put a buckle on in these cases, but I'm sometimes kicking myself for not doing it.
That's a really good statement. Not just for diabetic cases, for other cases. I almost never get upset that I did put on a buckle, but I do sometimes get upset that I didn't. I like that. Okay, so we said the second major goal after relieving the traction, which we've done by dissecting and by retinectomizing and maybe buckling, is to maintain hemostasis while we're doing all this. And we talked about visualization before, and I did mention that if you have good visualization, you could avoid cutting blood vessels and pulling on things you shouldn't pull on. So you want to remove blood against the posterior hyaloid, like Gaurav showed earlier. You want a good microscopic setup, you want good lenses. All these things are really critical to prevent hemorrhage. But when we still have hemorrhage, despite doing all this, and it occurs, you've tried to prevent it, but now it's occurring, what do you do? So here's one thing you could do. What do you guys think about this? What's your general philosophy about raising the bottle?
I think, Dean, we've talked about this in the past, that not only you need to pay attention to what's inside the eye, but the outside the eye, right? You can raise the bottle, but you got to look at what's happening to the blood pressure. I think the blood pressure is an issue, and you got to look at the perfusion pressure. So, just raising the bottle doesn't always treat the problem.
Mike?
I do use elevated pressure in cases where I've got new focal bleeding, and I'll oftentimes let it go a minute or two, but I've got the machine barking at me, telling me how many minutes I've had the pressure elevated, and I try to lower it so that I can, reassess if the bleeding has stopped. If it hasn't, there are a couple of other things that we might talk about here as far as tricks to try to stop the bleeding in cases where the elevation of the IOP doesn't do it. And so, yeah, but I mean, I think that one of the issues for controlling bleeding is that, some of these cases, you get a little oozing of blood out over the posterior pole, and you really have to peel it all over again. It becomes another fibrotic membrane that you almost have to spend as much time getting off as the first one. So you want to definitely make sure you don't have bleeding, and just got to do what you can to control it. This is one method, but it's not the ultimate method if you got really bad bleeding and you got to keep the bottle up a long time.
Yep. Well, here's a case. Look carefully at the nerve. So I raised the bottle, and what do you see going on here?
Look, pulsations there.
Pulsations. So I did exactly what Gaurav said. I said to the anesthesiologist, what is the blood pressure? This patient, I believe, was under general anesthesia, and in our OR, they like to keep systemic blood pressure really low, and I don't know why. And this patient had systemic blood pressure of 80/40 while in the OR under general anesthesia. And clearly you can get a lack of perfusion when you elevate the bottle and your systemic blood pressure is low. And I think sometimes people get post-op loss of vision, either due to an infarcted nerve or infarcted retina, and they never know why. And it might be because of this, because you raise the bottle and you don't realize that there's very little perfusion pressure pushing blood into the eye once you've raised the bottle. So I told the anesthesiologist, please raise the blood pressure to 120/80 or something, and a little more compatible with human life, because the eye is going to be in trouble if we keep the bottle higher. And they did. They lowered the infusion and those pulsations went away. So pay attention to that. Every now and then a fellow's peeling an epiretinal membrane, and for whatever reason the bottle's up a little, or the blood pressure's really low, and the pulsation starts, and I say, what's going on? And I notice the fellow's not even actually noticing the nerve. They're so intent on peeling the membrane that they don't realize the big picture. So pay attention to this, and when a nerve is pulsating, lower the systemic blood pressure or lower your infusion bottle. Do you guys like diathermy to control bleeding?
Go ahead.
No,
I was going to say,
ahead.
I was going to say that I use diathermy some. I certainly use it in places where you've got bad bleeding and you have a break. I also have found that endo laser can also control bleeding, and that's something that Steve Charles talks about a lot, that he doesn't use diathermy. I would never say that I don't use diathermy, but I do try to use the endo laser some, which I think is pretty good at controlling bleeding. Sometimes if I have my soft tip cannula in there and I've got some bleeding, Cindy Toe taught me the technique of just pushing down with the soft tip on the point of bleeding. And sometimes you can get some hemostasis that way without having to do diathermy or laser. So those are my techniques.
I agree 100%. I tend to use actually endo laser more than diathermy, except in some of those cases where you do need diathermy. Actually, I wish D.O.R.C made an instrument for 25 or 27, but they have a 23 gauge diathermy with extrusion that you can puff the blood away and diathermize at the same time, because sometimes that's the only way to control the bleeding. the other problem with diathermy is sometimes it'll get stuck to the tissue as you're diathermizing. And as you get stuck, sometimes you can cause a break as a tissue gets pulled up, which typically will not occur with endo laser.
Good points. So for these cases, we're going to talk about tamponade, and I'm going to give you a bunch of scenarios in a moment, and you can tell me which tamponade you'd like. So let's start with the top. You have a diabetic vitrectomy you've done, you've dissected some membranes, and you're pretty sure there's no break. You're close to 100% sure. What are you going to leave in the eye? And you have your choices on the right. I think most people are going to agree we're going to use BSS, right? Is that what you guys
Agreed.
Yeah.
So what about you've peeled, you don't see a break, you're really not sure. There could be a micro break somewhere because you did a lot of peeling in this case, a lot of dissection. You don't see one, but maybe not. What are you going to use? If you use BSS, you could get burnt. I don't know. What do you guys do?
You know, Dean, in a diabetic, when you've got, you've got a lot of laser in there, and usually the part that isn't treated with laser is pretty obvious whether you have a break or not. I think that you can go with either BSS or air. A lot of times in these cases, I'll just leave them with air.
Yep, air.
That's what I use for these. How about, there's a break? Does it matter where the break is? But there's a definite break. What are you going to use? And don't maybe one or two small breaks, nothing big. What are you going to do?
I like to use the shortest acting gas, Dean, SF6. I think whether the break is, unless the guy can't position or person can't position at all, I think having gas in an eye for a longer period of time doesn't really do any good. I think it causes more harm than good. So I like SF6 gas, whatever percentage you want.
Mike?
I think that if the break, the positioning to me, like this, we can get into this. I'm not big on face down positioning because I don't think these patients do it. And so I kind of try to figure out where the break is. And if it's above the horizontal meridian, I'm asking him to sit up during the day and sleep on either side. If it's on one side or the other below the horizontal meridian, I'm going to ask him to be on their side. Like I said, I'm rarely face down for these cases. But it kind of depends on where it is and how long I feel like it needs to be pressed on. But I'll either do SF6 rarely, sometimes C3F8.
Well, I lean towards C3F8, and it's not for the duration. I don't really want a gas bubble that lasts 2 months. But I do think occasionally when I use SF6 in the first few days, the bubble is suboptimal. So if I have a less gas fill, then I'm hoping that's worse if you've got SF6. So that's why I lean towards C3F8. I seem to get a better bubble in the first few days, but I wish it went away quicker. So
And Dean, I think in those cases, it all probably depends too. The patient's pseudophakic, use a little bit of expansile as SF6. A lot of times they're pseudophakic, and you can get a pretty good fill, almost 90 to 95%. But I agree that if you think you need C3F8, use C3F8.
All right, how about you do a small focal retinectomy? What are you going to use then?
I still think you could use C3F8, or SF6. Depends on location.
Mike?
I think either one. Again, for the same reasons you just illustrated, the C3F8, if you want to get a bigger fill because it's maybe an inferior focal retinectomy.
How about the large peripheral retinectomies? Do you use any particular agent there?
I think if you've got a large peripheral retinectomy, the patient probably has pretty severe disease, Dean. And if the potential for the eye, if it's 2100, 2200, you're not sure about positioning, I don't think it's it's unreasonable to use silicone oil in these eyes. So I think that sometimes maybe we underutilize oil in these eyes because these people want to be functional.
For me, Dean, the issue is that, if a patient was phakic and they were made aphakic as a result of the surgery, which often happens if you're going to be doing one of these retinectomies, then I'm going to use oil because I can take the oil out when I decide on whether or not I put a lens in later on. Sometimes I do, sometimes I wouldn't in those cases. And then if it's a peripheral retinectomy, I would, in a patient that's pseudophakic, I'd probably use C3F8.
So I like oil for the big retinectomies. And when you guys put in oil, how long do you leave it in for?
I think Dean depends, but I want to make sure that all of the neovascularizations regressed, that there's good PRP that has sort of matured and taken place. But I don't think we necessarily need to keep oil. And there's some patients I've seen that have had oil for whatever reason, like a year or 2 years. And I think that at 2 to 3 months time, I think if the eye's stable, you can take the oil out. And if they're phakic, I just combine it with the cataract doctor at that point, take the lens, have them take cataract and take the oil out.
For me, if it's, usually we're planning on taking it out at the 1 month visit, which means it'll be probably 2 months to 3 months afterward if everything's going very well. One
Yep.
thing that we didn't really talk about with silicone oil is, at least when I was in training and early on, was, people talked about the use of silicone oil in these eyes that had just recurrent severe hemorrhaging, and that there was a sort of an a coagulant effect, or some a kind of calm down. I think they used the word calming down the PDR in patients by using silicone oil. And I don't know if I ever bought into that, but there have been cases where, when you've gotten a couple or 3 surgeries because they've had recurrent bleeding, that, they end up getting a lensectomy and they get oil in their eye, just, which I think does kind of keep them from, in some cases, from having recurrent bleeding.
Dean, I think, and add to that point, the eyes that typically will require oil for a longer time are the ones that have some hypotony before surgery, that they've already got some anterior contracture. And I think in those eyes might be useful to leave the oil for a longer time.
Yeah, and it's also critical what the fellow eye status is, right? A lot of these diabetics, as you alluded to earlier, are blind in the other eye, and this eye becomes the better eye. But if it is the better seeing eye, I tend to use oil in those too, so that the patient can be functional during the time that they're healing. All right, so we've got post-op complications. One of the most common and one of the most annoying is post-op vitreous hemorrhage. So what are you going to do when you see a post-op hemorrhage? There's no rubeosis. There's just a post-op hemorrhage, and it's fairly dense. You just did a straightforward diabetic. I mean, straightforward means it wasn't just a non-clearing hemorrhage. I mean, there was probably some dissection involved, but it wasn't a killer case. What do you guys do?
So for me,
go ahead.
Go
Dan.
ahead, Gaurav.
I saw Mike, and one thing I don't do is an in-office air fluid exchange. I was never good at this, or never really found this to be that useful. But I know there are very smart people who do it. But it's really anti-VEGF therapy. You can try an injection or so. It really hasn't worked for a lot of the patients. But you kind of prepare them, hey, if it doesn't clear after anti-VEGF, we need to do surgery. But doing this in the office is something that I don't do.
Mike?
So for me, I think I categorize this as being, is this a persistent hemorrhage, meaning they had blood post-op day 1 and it just stays, there's blood that just stays there? Or is this recurrent hemorrhage, meaning they had a period of time where their vision was good and then 6 weeks later they have another bleed? Because I think it matters. If it's a persistent hemorrhage where they had it from day 1, I will sometimes offer up an office fluid air exchange in those patients, because I think half of the time that works. I do give it time though, because every once in a while I'll tell a patient, you just, if you can stick with this for a while, sometimes, if we go a month, sometimes all of a sudden this just clears pretty quickly. And sure enough, every once in a while, they'll tell me that it was really bad for 3 weeks, and then over about a 3 or 4 day period, it just cleared out. And I don't see why they had the blood before, and I don't, except maybe their sclerotomy used, and they just had blood that eventually cleared up, maybe as their ciliary body kicked in and they were starting to circulate a little better. But the ones that are recurrent, I do start worrying about, whether they have anterior hyaloidal fibrovascular proliferation, and I I will be more likely to take them back to the OR.
So I like the way you categorize the two groups. If the hemorrhage is present on post-op day 1, it's probably due to an oozing vessel that was cut during surgery, during the dissection. Sometimes it's sclerotomy related. Your sclerotomy can bleed. But if it's recurrent, it could be as the sclerotomy heals, new blood vessels grow into the sclerotomy. That's how it heals up. And sometimes those bleed. But sometimes really bad things are going on, like you just said. So what about preventing post-op hemorrhage? I find that, if you do a thorough laser, remember, you've already removed the hyaloid, which is the biggest problem. And now you laser. I use the lighted curved laser with scleral depression, and I go all the way to the aura in these cases. I have concluded that they have failed PRP, and that's why they're in the OR. And this is my one chance to fill the eye up with laser. So I give them a very thorough endo laser, and I think that reduces the probability of problems later on. But what about giving Avastin at the end of the case to prevent hemorrhage? Do you do that? I sometimes use this.
I haven't, Dean. It just logistically, it's hard to do this for us
Okay.
at the end of the case.
I haven't done it, but it makes sense to me, although, you're putting it in a vitrectomized eye. I don't know how long it'll last, but it does make sense to me if you're talking about like sclerotomy related leakage or some neovascular furon that you've just dissected from, and maybe you can keep it from bleeding a little bit. It makes sense to me. It doesn't take much blood to really cause a bad, vitreous hemorrhage in a vitrectomized eye.
And Dean, going back to your point of lasering, that's why I think it's important that you remove all the blood down below in a diabetic as much as you can. Even if they're fake, it can be safe, because that's where you want to really put the PRP all the way up to the aura. And those patients will get the hemorrhage that Mike described day 1. But it's important, if you've already put your laser in, that I'm much less aggressive to take that patient then back to surgery.
Yeah, some people are minimalists, some people are maximalists. I think for bad diabetics, it's good to be a maximalist. Get rid of all that hemorrhage, like you said, good membrane dissection, thorough laser. Mike, you're going to say something?
Well, Dean, you pointed out that picture with the lighted endo laser, curved endo laser probe. I think that lighting and curved laser probes are very important for these cases, especially in a phakic eye like you have shown here. There's a lot of good research to indicate that, you can get all the way to the aura, even in a phakic eye with a curved laser probe. And if it turns out that I've used a chandelier during the case, then I will use a regular curved laser probe and do the laser that way. If I've done during the case, I didn't use a chandelier, I'll use the lighted curved laser probe and do depression myself. I think that is really good for the fellows that are on this call who are going to be kind of finishing their training and they don't have their own fellow to do their case with them. Getting facile with a chandelier or the lighted laser probe is very important for these diabetic cases.
Yeah, I think they've revolutionized the treatment of diabetic
and Dean, if they don't have that, then they can always use the indirect laser. I know it's got kind of a hassle, but the indirect is always there.
Yep. Okay, and I think it's really critical to suture sclerotomies in diabetic cases, because if the eye is hypotenuse overnight after the surgery, they're more likely to ooze than if the eye has a normal pressure.
Dean, one thing I just want to add to that is at the end, when I'm lasering, I actually lower the bottle to, let's say if I'm operating at 30 to about 15 to 20 to see if they're oozing, because their pressure post-operatively is not going to be in the 30s. So it's a great way to have these areas that you can treat beforehand.
Yeah, I'm glad you mentioned that. Great point. That's like a provocative test, right? You see if there's any oozing and you deal with it. All right, so now you have some rubeosis. Okay, so what are you thinking? You got a vitreous hemorrhage and rubeosis. Do you go in right away and operate on these? I do. Post-op, let's say it's post-op 1 month or 6 weeks or 2 months, and this happens with a vitreous hemorrhage. I operate it immediately.
I would. I mean, this is a phakic patient. The lens has got to go. This is one of those kind of trying to save the eye things.
Yep. All right, Mike, this is your case. You see some rubeosis post-op. And should I go to the next slide, or you want to talk before?
Well, I mean, this is a post-op phakic patient who's got rubiosis. I mean, there's a type 1 diabetic who had a tough, complicated traction detachment case. And so, you've got to think more than just the anterior segment problem. Go ahead. So this is a patient in which there's actually, neovascularization growing on the posterior capsule of the lens. And this is the most profound example of anterior hyaloidal fibrovascular proliferation I've ever seen. And this person, this is when you have to take the lens out. You've got to really dissect the vitreous base. When you do that, it just bleeds. There's just millions of points of bleeding as you're cutting along and shaving the vitreous base, and you laser that vitreous base thoroughly. And I put oil in these cases, do an inferior PI and put in oil.
So we have 3 minutes left, but we started a little bit late, so let's go a little bit over. Not much, a little bit. But so anterior hyaloidal fibrovascular proliferation, I find that fellows really don't know much about this. And Mike, I'm glad you included these slides here because this is a problem. And Mike, tell us about this. It used to be a common problem, but now with the lighted curved lasers and all the things we talked about, the small cutters that you can get in the periphery and remove more vitreous, we don't see it as much. But which patients have this occur? You have it listed here, but tell us.
Yeah, I mean, the people that I worry about with this are the bad diabetics, oftentimes with young eyes that you really are hesitant to want to remove the lens. They're not pseudophakic, and so you're leaving, quite a bit of anterior vitreous behind, and you're leaving vitreous maybe behind the lens and a lot of the vitreous base. I think that now with the visualization, I think the reason that this is probably a much lower percentage now, and I don't know if that's true or not, but I feel like it might be, is that we do a better job of getting the anterior vitreous out even in phakic eyes. But if they've got a lot of ischemia, if you don't get a lot of anterior laser in, then you're at risk for having this happen. And when it happens, it's very difficult to turn these eyes around. A lot of times they go hypotenuse because they've got proliferations over their ciliary processes, and it's a mess.
I did a case a few months ago, and it was a very bad diabetic, and I left the lens, and I was really happy I was able to leave the lens despite a moderate cataract, and the patient got anterior hyaloidal. And I was so mad in retrospect that I left the lens, because here I went through pain to do the surgery to leave the lens, and he would have been better off without the lens, because then I would have been able to remove more vitreous. And it's the phakic eyes that get this problem. I don't know if I've seen many aphakic or pseudophakic eyes that have AHFP. So here I struggled, I left the lens, and he got the complication that is not very common, but it's bad when it happens.
Mike, the only thing to add to your and Mike's comment, Dean, is the patients I've seen is also you need to make sure that they don't have a carotid disease, because a lot of these patients have concomitant carotid disease. And I've had probably 3 or 4 patients who have had this, and they all turn out to have silent carotid disease. That's
a good point. Very
good point.
All right, so let's go quickly through this, Gaurav. This is your patient.
So yeah, this is a patient that Dean, this is a gentleman who I'd done PRP, but he never showed up for about a year for COVID. So he was doing well, and he came with this. He had a tractional detachment that had now starting to involve just next to the fovea. So this had progressed. So here we're just sort of showing the principles of the hyaloid, and I'm using the cutter to get in these spaces, and you can see the area of detachment. And again, I'm not using a chandelier, but I'm just using the cutter to go in these spaces. And the thing I want to show here is that this patient, again, hemostasis was an issue. But when a blood does or bleeding does occur, you need to kind of not worry about it as much as as people do, and try to do your laser as much as possible, and then go back and forth and back and forth. And I try to use on these patients typically a flow base rather than a vacuum, because everything slows down. That makes the hemostasis a little bit easier. And again, just showing some of the points that Dean and Mike talked about, as knowing where the hyaloid here, showing the laser treating the areas of the neovascularization. Now this clot is, what do you do with the clot? I typically don't like to remove them, unless they're large like this. But what I worry about, and here's diathermy, is what is underneath that clot. So slowly and surely, now here we put blue in, we peel the ILM and so on and so forth. But I think it's important with hemostasis is that the surgery must continue if you can. So once we're sort of peeled, then you have this blood pressure is high, but slowly but surely we try to get the blood off, not from anything else, but to make sure there's areas of bleeding, and you want a laser underneath that. So this patient's the other eye, again, had to be functional. So we actually put oil in this guy because there were some issues of some breaks by the inferior proliferation. We didn't make a break, but I'm sure there were breaks. This guy, for his work status, needed to have silicone oil, but otherwise I would have just put in, gas in him. But for him, it's a special reason that we put oil. But the notion is that you really need to have hemostasis not hinder the other things you need to do.
So here's his, you want to tell us about this? This was his post-op day, what, 1?
Yeah, this is post-op day 1, and he was pretty happy. Obviously, I think it's like 2,100 or 200. This guy mixes chemicals. His other eye, I don't think, has great vision. So this is the kind of bleeding, despite all of our things that we did. This is what you get post-op day 1.
This
right?
guy with the bad hypertensive, is that what you had told me?
Yes, yeah, blood pressure's in the 190s, right? So obviously, this is the kind of patient who would have had a dense vitreous hemorrhage day 1, as Mike described, with a gas bubble in the eye. But I don't like to leave oil, with a lot of blood. But here, obviously, we didn't have too much of a choice.
Yep, nice. So Gaurav, we have 2 final topics. They're both brief. Gaurav, why don't you tell us about the D.O.R.C vitrectomy for diabetic macular edema protocol D study. I think we have a summary.
Yeah, so I think that obviously everybody's techniques are different with diabetics. And I think this study really showed that, vitrectomy was not advisable for these patients. But I do think it is advisable for a small percentage of these patients. And I define them into two types. Diabetics who have surface proliferation, I do think those patients are helped by vitrectomy along with anti-VEGF and other agents. But there are other patients who you've done everything possible and nothing is working. In those patients, if they did have some improvement in vision after steroids or anti-VEGF, where that's one of your best markers that vitrectomy with removal of the cortical vitreous and ILM is going to be useful. And for that, those patients, you need to look at the OCT to look at the ellipsoid zone. So I think sometimes there are diabetic patients who have surface disease and have gotten their 200th injection, and they've got a massive pucker that's causing their edema. So sometimes people are afraid to do vitrectomy in these patients, but I think those patients can be helped. The ones without an ERM, it's questionable, except in small percentage of eyes. I know that Dean and Ron Gentili wrote a paper that the ILM in these patients actually have a muscle-like response. They act like muscles, smooth muscle cells. And but it is important, if you do that, you peel the ILM.
Yeah, you get actin, basically, muscle-specific actin that the cells produce that grow along the ILM. It's really quite amazing. All right, and that even happens in macular holes, not related to diabetics, but if you look at the gas classification, stage 3 and stage 4 macular holes, you actually do have some muscle-specific actin on top of the ILM, and that's probably why peeling the ILM in those cases helps.
There's an argument that, we shouldn't be doing vitrectomy in patients, who might benefit from anti-VEGF in the future because the anti-VEGF doesn't work as well in a vitrectomized eye. But there was a sub-study looking at one of the D.R.C protocols for anti-VEGF injection therapy, and it turned out that a lot of a certain percentage of the patients who got into the study mistakenly had a vitrectomy and mistakenly got into the study. And it turns out that their outcomes weren't as bad as one would think. And so it didn't seem to make as much a difference as we sometimes worry about with vitrectomy and anti-VEGF use.
Yep.
Yeah, and my going to that point is in a vitrectomized eye, VEGF gets cleared 400 times faster than a non-vitrectomized eye.
Yeah. All right, let's do the final 3 slides in 3 minutes so we can finish at 10:10 because I think we started it a little late. So Mike, tell us about this.
Oh, this is a patient that I still follow that has actually quite excellent central vision, but you can tell they're functionally blind because of the really severe atrophy that they've experienced over the years. Now, this is a patient who got really kind of D.O.R.S style laser back in the late 1970s, early 1980s, in which they got a row of laser inside their arcade, and then they had fairly dense PRP, but the patient also happens to be a myope. Now, the PRP didn't look like this from day one, but over the years, this PRP has coalesced, the scars have coalesced, and the atrophy has creeped into the macula even more, to where this patient really has no peripheral vision and very little central vision.
So what's amazing is I have a patient in my collection with the same thing, and slide's not advancing. Here we go. Thanks, Monica. And you can see it's the same thing. So I don't know where she had her PRP, but this is pretty bad. Exactly what Mike said. I mean, this expands over time. I don't think the other doctor did a PRP like this. In fact, I'm pretty sure he didn't. I would say that these spots expanded over time, and looks a lot like the patient Mike just showed. And finally, the last slide is look at this patient. On the left, you see a fundus photo and an autofluorescence taken in 2014. And on the right, you see the same patient in 2019. No additional laser was given, but the laser spots have expanded. You can really see it nicely in the autofluorescence. And this was a myope, exactly what Mike just said, that over time, these spots expand. And sometimes you got to be a little careful lasering high myopes with hot burns, because this could happen. The other thing about laser I want to mention is sometimes when I'm doing endo laser in the OR, I try not to go too crazy on the 3 o'clock and 9 o'clock spots, because the long posterior ciliary, the long ciliary nerve, you can cook that thing. And in somebody with a blue iris, they'll get a blown pupil and they won't be able to accommodate, and they will be very unhappy. Sometimes it recovers, but sometimes it doesn't. So I look for that little railroad track, which is the nerve that you can see at 3 o'clock and 9 o'clock, all the way to the periphery. And I do not laser the nerve if I can help it. Obviously, if there's a retinal break there, I have to, but otherwise I don't laser it. So that is the last slide. So thank you, everyone. Mike, Gaurav, thanks a lot for your comments. I really appreciate that. Those were wonderful, and for the slides as well. Monica, I want to thank you tremendously, as well as your team from D.O.R.C for providing funding for this educational experience for our fellows and others out there. So really appreciate it. Thank you very much. Monica, you want some final words?
Yeah, I'd like to thank you all, our presenters, and for everyone who attended. You can watch this and other episodes of the Retina Connect series on the D.O.R.C International YouTube page. And we thank you for joining us this evening.